Hello, everybody. This is Nakul Rathi, and I will be talking to you about implant restorations today. So let's get to it. Thank you, Indian Prosthodontics Society, for giving me the chance to uh, to present the topic that I really adore, and I love to lecture on it. I love to talk about it. It's my passion, and we'll discuss a couple of nuances about this topic in the next half hour. Okay, we'll be talking about the restorative solutions of implant dentistry. Right, I am Nakul Rathi, and I'm the co-founder of Get Implant, which is an implant company based out of Houston, Texas. I do a couple of disclosures to make. I do lecture for Hyosin and Strawman, also for Carestream Dental and Accurata. So really involved with a lot of CAD, CAM, and digital technology here in the US and in India as well, where I practice. So during my presentation, I think I'll be talking a lot about a few of these products, but most of it would be backed by some research and a little bit of what I do in my personal practice. Right, I come from the great city of Nagpur, right in the middle of India, and I'm a proud alumni of Government Dental College and Hospital in Nagpur. And then I went on to do my prosthodontic residency from the Ohio State University in Columbus, Ohio. And it is a program which has had a pretty good influence on prosthodontics in general. Dr. Boucher, Carl Boucher, was program director of this program for over 30 years. And Dr. Stephen Rosenstiel was also a faculty in this program. He's currently the editor of the Journal of Prosthodontic Dentistry, and was very honored to be a part of that great institute. And now I have my own private practice in Houston, and I do practice in India as well, in Nagpur. So what we'll be discussing about today is just implant prosthodontics in general. What are the different types of implant prostheses that we can make? A little bit about components, but we'll dive in detail about just two specific implant prostheses: a single implant crown and full arch restoration. Now, these topic by itself can take, well, 3 years or full residencies to cover, but I have 30 minutes to just touch on a couple of points that I think would make your implant prosthetics really easy. Okay. So in general, implants can be restored or provided to the patient to restore single tooth, just like in this case, or 2 or 3 teeth, or FPDs, or full arch restoration, right? Can be done with implant. But this is in the fixed realm. Now, for removable prosthetics, implant can be used for giving retention for a full, complete implants retained overdenture, or partial dentures, like you can see here. You can avoid clasps, you can avoid, and they're very comfortable. Less used in general, but I think they're great for patients who A, may not have the bone, or B, may not have the financial resource to afford a fixed solution. Implant retained partial dentures are a great solution. Right. So in general, from a restorative standpoint, what we are doing with implant is creating a root analog, right? And there are various components that we will be using to provide a tooth on, or a crown on that root analog, right? And here you can see for single implant restoration, these are the general components that we would use. Open tray, closed tray, impression posts. But when we talk about these different types of impression techniques, I think the most common that I used on a routine basis is either an intraoral scan, or if I'm going analog, it would be an open tray impression post, right? So we place the open tray impression post after the implant is healed. We're only talking about the restorative aspects here, right? We're not talking about the surgical aspects. So for the restorative aspect, the impression post goes in, and then once the impression is done with addition silicone, which is probably the impression material of choice for doing implant impression, we transfer that to the analog and pour a model. Once the model is ready, we put the abutment on it, and then we design a crown on that model, right? And we can take this designed abutment, it could be custom abutment, or it could be a stock abutment, which has been used for fabricating that crown, for fabricating that prosthesis, and then we place the crown back. Now, this type would be a cemetery tape. And if we have an access hole on top of this, it becomes what we call a screw-mentable crown, which is cemented but has the properties of a screw-retained crown. Right? So just to tell you in detail, there are various ways in which you can restore a single implant. We can make a prefabricated abutment or a stock abutment and cement the crown like we just saw. We can have a custom abutment, which is a milled abutment, and then we can cement a crown. We can have a full screw retained crown, which is basically a UCLA type abutment where the crown has been made with casting and then layering porcelain directly on the abutment. All the new zirconia screw retained abutments are essentially a prefabricated abutment on which the crown has been cemented with a screw access hole. So it's kind of a screw-mentable crown, because we are using a cement component to cement the zirconia crown with the titanium abutment. The less common types of abutments and crowns for single implant are solid abutments and single piece abutments where the prosthetic is just directly cemented on. There are disadvantages of using these two types, and so they're less common. The most common one that I use is either a custom abutment with a cemented crown with access hole, or a stock abutment. But I do try to keep an access hole wherever possible. And if it's not possible, then we end up using a temporary cement to cement it. Otherwise, when the access hole is open, we can use resin cement or a glass ionomer, which is a permanent hard cement. Coming to what impression techniques do we use for single implant? Open tray, closed tray, digital, all three can be used. Documentation and my thesis was on digital impressioning for implant. And during our studies, we know that all these three techniques are very accurate to deliver a single implant prosthetic, right? And open tray, closed tray, digital. The most I would say about 60–70% of my practice, we use intraoral scanning now, right? And we'll just go over a case where we use that to fabricate a single implant crown. So implant for a non-restorable number 15, or number 4 from the US nomenclature. A single implant was placed, healing abutment, and then after 3 months of healing, we can see the soft tissue around the implant is pretty healthy. We place a scan body, which is actually an impression post that we use for doing a digital scan. When we are using a scan body, most of the systems would allow you to do 2 scans. One would be a scan of the scan body attached on that implant. And then the second one would be just the scan of the soft tissue without the scan post. Now, what this does is allows the lab to understand what the soft tissue contour is, and the scan body scan gives them the orientation of the implant. So now they can fabricate a very good custom abutment, and then they can also fabricate a very good implant crown on top, right? And generally this fabrication, there are 2 or 3 common CAD softwares that are used. ExoCAD being probably among the most popular ones, and 3Shape and ExoCAD are probably the more popular softwares used for designing these. There are other softwares that have come up now, like Blue Sky Bio, Dental Wings is another common one, Blender. There are many other softwares that you can use to design these abutments and design these crowns digitally after we take an intraoral scan, okay? And once we have designed it, we can manufacture this using CAD/CAM, right? Milling or printing. For abutments, which are generally made of titanium, milling is the preferred option for making implant abutments. So this is a milled titanium abutment, and the model is 3D printed. And on the milled abutment, we have this milled zirconia crown that was designed here, right? So this designed zirconia crown is milled and then sintered, stain and glaze, and then we get this crown. Now, the good part about this crown is here you can also see that there is an access hole that is designed on the zirconia crown. So we will be able to place the abutment and check this crown. We check the contacts, we check the occlusion, make sure that we have a good broad contact on these crowns and light occlusion on these crowns. We check the occlusion, we check the contact, and then we can cement it intraorally. Now here you can see very clearly that there is excess cement that went down from the crown when it was cemented. But the advantage of this screw-mentable design with the access hole of the crown on top, you can see the access hole right here, the access hole of the crown on top, is that we will be able to unscrew it, clean the cement outside, and then screw it just like a regular screw retained crown. Once we take it in, we can torque it using our torque wrench. Check the contact again and put some cotton or Teflon tape in the access hole, and then finally put some composite to cover the access hole. And we can do this very, very predictably just from an intraoral scan, right? Now, if we are going the non-digital route, my preferred way of doing it is through open tray impression. Why open tray and why not closed tray? I think open tray just gives a more secure impression post inside our addition silicone. There's less chances of error when we are taking the impression post in and pushing it, impression post out and pushing it in the impression. Once it's locked in an open tray, it is less chances of error. Here you can see the healing abutment is there. It's the healing abutment. We see a nice tissue band around the implant. Place a open tray impression post there. Make a small hole in the stock tray that we use here. And then we do the impression with addition silicone. Now, this is a common question, that which impression material to use. Now, addition silicone for sure, but which type? Do we use putty? Do we use light body? Do we use heavy body? I think heavy body and light body just around the soft tissue, just like we do for a crown and bridge, but instead of regular body, we can use putty or heavy body. Now, the advantage of that is that an open tray impression post will get locked in it. And because of the rigidity of the heavy body and the rigidity of the putty, the movement of that impression post inside that impression tray is going to be very, very less, which will mean that our impression will be a lot more accurate, right? And once we take this impression out, here you can see the impression is out, we can place the lab analog on this model, on this impression post. Now we put some soft tissue and then pour the model. The lab prescription is sent to the lab. Just provide a little more detail is the point of that slide. Just don't tell the lab to make a crown, just give them a few more details. Definitely tell them what type of abutment do you want? Do you want a stock abutment, a custom abutment? And then what implant brand are you using and what size? This is critical information that the lab can use even to put the right driver for your prosthetic, right? So always tell this to the lab and tell them to make an access hole if you want, if the case permits, try to make an access hole. I think that's that'll make your life and your patient's life a lot easier, not just for the delivery process, but for the long-term care of that crown as well. Okay, try to make tell the lab also to design a crown with very light occlusal anatomy and light occlusal contacts, and tell them to give a broad proximal contact. Okay, so here is the crown which has been designed and milled, and that's a stock abutment right there. Okay, stock abutment was tried in the same direction. So this flat end is on the distal here, and here you can see that the flat end is on the distal of the crown on the model. So just take it, put it in. You can try the crown on, get the contacts checked. We can place cotton or Teflon in, dry it, and then cement intraorally. Once you cement intraorally, you can quickly take the cotton out and your screw access channel would be patent to be able to put the driver in and unscrew that abutment crown assembly. Now, once you unscrew it, you can see there's extra cement at that interface of the crown and the abutment, which can be cleaned a lot easier outside the mouth than inside the mouth. And once you clean that, you can take this back and use it just like a screw retained crown. Torque it again, check the occlusion, cover the access hole, cotton, composite, easy peasy, right? Very predictable, works all the time. There are complications that you can get with single implant crowns. Obviously, there's crestal bone loss, you can get some dislodged crown, screw loosening, fracturing, restoration fracturing. And as prosthodontists, I think since more and more people have started restoring implants, we will be seeing a lot of these complications that we will have to handle. And implant failure is not end of the game. There are a lot of things that we can do to salvage the situation and even redo the implant. It's not a big deal. Okay, so let's talk a little more about the fixed, full arch fixed prosthetics, right? A lot more things that can be done with fixed, and a lot more types in which we can fabricate a full arch prosthesis. It can be based on the type of connection, type of retention, screw, cement, combination, material. We can see how many parts our full arch has been split into. We can base it on the amount of occlusion that has been provided. It can be all on 4, 5, 6, 8, I've seen 10 and 12 as well. So there's just a lot of different things that can be done. Do we give cantilever or not? In this, I just want to touch on the two main aspects, which is based on the prosthetic connection. And I think when I practice in India and when I was practicing more in India, we used to do a lot of implant level prosthetics, even for full arch. And I think the more and more I've started doing abutment level prosthetics, I see the advantage, and I will talk a little more about that. And then going from screw retained, from cement retained, sorry, going to screw retained, or a combination, which is screw-mentable, even for full arch. I think it is going to make our job as dentists a lot easier in the long term, because the maintenance and everything for a retrievable prosthesis is a lot easier than a prosthesis which has been cemented and is very hard to remove. Okay, so we'll be touching on these two aspects a little more. When we are designing these full arch prostheses, a classification from MISH, which is defining the fixed prosthesis in FP1, 2, 3, based on what we are trying to replace. Are we trying to replace only the tooth? Are we trying to replace the tooth and the papilla, or maybe a little bit of the root, which is FP2, and FP3 would be that we are trying to replace the pink and the tooth in the prosthetic, right? So very straightforward classification. And this picture from digitaldds.com is very nice to explain what the difference is. This is FP1, that's FP3, right? So just two different types of prosthesis. And this is a clinical situation of FP1, clinical situation of FP3. Right? So let's talk a little more about the difference between implant level and abutment level, right? Implant level prosthetic can be done in screw retained and cement retained. Screw retained is using UCL abutments, casted, and then screwed directly on the implant. Abutment level, which is more common of what I used to do, is basically we take stock abutment or we mill custom abutments and we place them in a way that all the abutments are parallel, and then we cement a full arch prosthesis on these abutments, right? Fairly straightforward. If you're doing that, just make your life easier by just adding screw access holes, okay? This is a very doable prosthesis, predictable, not very hard to do, but there are disadvantages. Now, this is a pretty difficult prosthesis to make, which is directly screwed onto the implant, where we have a prosthetic which has a connection and the crown in one piece, and we are screwing this directly. We have to make sure that there's a lot of parallelism. It can be a beautiful prosthesis if done well, but it's very technique sensitive and takes a lot of appointments, and hard if there is any chipping or any fracture of the prosthesis. Pretty tough to maintain over long term, right? But the results can be very good, and patients who get these are pretty happy. But now what I've started doing almost on a routine basis is, instead of going from implant level, go to abutment level. By that, what I mean is, initially when Brennemark started doing these full arch cases, they had all the implants which were external hex. The prosthetic was made on top of the external hex of the implant body. The connection that we have now are all internal hex. So what we have started, what we know now works a lot better, is changing that connection from an internal hex to an external hex using what we call a multi-unit abutment. And that multi-unit abutment is going to make the new full arch prosthetic a lot easier to fabricate, a lot easier to maintain over long term, and we'll discuss the advantages here. Now, going multi-unit gives us one big advantage, that even if our implant is a little tilted, we can use an angle correction multi-unit abutment, just like we did. This is an angle correction multi-unit, and we'll discuss a little more. The second is that we are not going to disturb the soft tissue as much, because with the implant level prosthetic, every time we do a certain step like impression, metal trine, bistrial, we are removing the healing abutment, and there is a damage of the hemidesmosable connections that happen between the abutment and the soft tissue. But with these, the multi-unit abutment is placed once and it's there forever, which makes the prosthetic steps a lot easier. We don't have to numb the patient every time. All the impressions and the trines are happening above the soft tissue. And it becomes very retrievable. It takes less than 5 minutes to remove a screw-retained prosthesis. And it's not just the retrievability of the prosthetic, but the retrievability of the abutment itself. So I've had cases which came back after 5 years, 10 years, where the abutment is fractured or the abutment screw is damaged, right? I'm sure a lot of you have seen that also. The advantage of doing multi-unit abutments is that if the abutment screw or the abutment has any damage, we can replace the abutment itself completely and still use the same prosthetic. Now, in a cement retained prosthesis, like this one, if one of this abutment fractures or fails, it is almost impossible to make a same abutment like this. Whereas if a multi-unit, a milled multi-unit fails or fractures, or there's a screw that gets stuck in it, we can just pick the same multi-unit from the same manufacturer, and the prosthetic that is made on top of that is going to fit perfectly. And the long-term maintenance, because of that, becomes very, very easy. Becomes very, very easy, right? So with the multi-unit abutments, there are different degrees of angle correction that can be done. 17 degree, 30 degree, 0 is obviously present, and then we can have different heights of the soft tissue as well. There are even 45 degree and 60 degree multi-unit abutments that are present. These are the multi-unit pictures of Get Implant system, which are pink in color, just for a slightly better aesthetic, because sometimes soft tissue can recede over time, and instead of having a titanium or a metallic color of the abutment show through, pink just looks a little better, right? And we can correct really strong implant angulations with these multi-unit abutments. Here you can see that the abutment goes on top, and then on the tilted implant also, we can have straight prosthetics and different prosthetic components like a titanium sleeve and a healing abutment that can go on top of the multi-unit abutment as well. And then the same lab analog like we discussed in our previous single implant case. Once this is placed and impression is done, we have an analog which replicates or which resembles the multi-unit connection. So let's go through a case really quickly. This is a mandibular case with Zimmer implants. We can see the implant with the healing abutment. We measure the soft tissue height, pick the right multi-unit, and torque the multi-unit in place. Take an open tray impression post, splint these with anything hard, which will give us a more accurate impression. Take an open tray impression, pour the model, verify the model by making a verification jig and doing a one screw test. And this is the upper, just regular denture, face bow, teeth trine, and then we can design a milled bar. put the prosthetic teeth back on the milled bar, process the denture, and here is the final prosthetic. This is the upper denture, but the lower implant supported fixed bar, which is screw retained, and then the denture is processed on top of that bar. That's delivered, and then we can cover the access holes with composite and cotton. Here you can see balanced occlusion from right view, protrusive, laterotrusive, and mediotrusive movement from a different view as well. So balancing denture in implant case is good, but not as critical. And here is the patient pre-post, right? Now these abutments are now, instead of using the titanium, we have designed new abutments which are pink in color, and we can do all these workflows like I showed you for the single implant crown as well, using scan bodies that go on top of the multi-unit abutment. So just to end, in general, there is a very big need of doing single implant. As per statistics, almost 10 to 12% of the American population, and I think that number would be a lot higher, maybe 15 to 20% of the adult Indian population, it has at least one tooth missing. Actually, 1/3. So in India, it would be about 330 or 350,000. Sorry, about a third. So 1/3 of the population will be missing one tooth at least, and about 1%, 1 to 2% of the population will be missing at least one jaw. So that's a pretty big number for us to restore. So in summary, for restoring these cases, try to use screw-mentable or screw-retained crowns. And if you have to go cement retained, just use some temporary cement. And then for full arch, I think using multi-units is the way to go, and is one of the most convenient and predictable ways of restoring these cases. Okay, thank you for listening, and I think I can open the floor for any questions if you have.